¿Ya estamos transmitiendo? ¿Ya podemos transmitir? So, good afternoon. Today we have a very interesting case. Uh, this patient is a 76 years old woman with a history of abdominal pain 8 months uh, in at least 8 months during 8 months, and CT scan finding of pseudocyst, pancreatic pseudocyst in the head of the pancreas. However, this patient this patient was sent to us to be evaluated for this pseudocyst and to perform a drainage. But we have several things that we need to analyze before to determine if this patient is this patient have a pancreatic pseudocyst. So first, we are at the level of the body of the pancreas. So you can see here the aorta with the celiac trunk and the splenic vessels, and we see here the main pancreatic duct slightly dilated in the body of the pancreas here. So I will perform a measure of this main pancreatic duct, and is slightly dilated. The pancreas is irregular also, is a heterogeneous pancreas, and I am following my pancreas until the tail. This is the kidney, so we are following the pancreas, and the main pancreatic duct is still irregular, slightly dilated in this area, but we also can arrive to see a dilation of the branch of the main duct. So you can see here. So this is the main pancreatic duct that is dilated. This is the part, the end of the body of the pancreas and the beginning of the tail of the pancreas, and this is secondary duct dilated also. Okay, so maybe we need to evaluate a little bit better. You see here, you see the main pancreatic duct with the secondary duct dilated. Here the main pancreatic duct, the secondary duct here. So we need to evaluate if this patient have maybe it's not a pseudocyst, maybe it's a main pancreatic duct lesion. Here we are at the level of the head of the pancreas. As you can see here, we don't have any pancreatic tissue. We see only this lesion here, and there is not more gland here in the head of the pancreas. So to my opinion, this is a intrapapular mucinous pancreatic cyst with that is taking the main pancreatic duct in the with more presence in the head of the pancreas, as you can see here. But also we have a lot of characteristics that we need to analyze. First, here this is the dilation. This is the cyst that is it's not a real cyst. This is the main pancreatic duct, totally dilated. This is a similar case that I had some years ago in Belo Horizonte in Brazil. That was also due to a MRI. There was thinking to be a pseudocyst, but it is not. This is the main pancreatic duct. So this is the dilation of the main pancreatic duct. The measure is 23 millimeters. We also have here some kind of nodule inside the main pancreatic duct, and if this lesion, we confirm that this is if we arrive to confirm that this is IPMN, this is a malignant IPMN, okay? Even if this is a malignant IPMN, these patients have several characteristics that is very important to be analyzed, because probably these patients could be sent to surgery, to my opinion. There is not invasion of vessels. There is not any other kind of situation that could perform a contraindication for the surgery, and we need to just to confirm that this is IPMN. So to do that, this is the here. So here, this is a common biliary duct. Okay. So first, for the characteristic to endoscopic ultrasound, we can say that this is an IPMN of the main pancreatic duct with a complete dilation and with features of malignancy inside due to the tisular areas that we can see here, or here, for example, is another tisular area. So here also. So for the evaluation, we can use just a fine needle biopsy and try to perform aspiration. We will see probably the characteristic of the fluid, and we need to evaluate that. But we will show you today a most complete evaluation of this lesion, because sometimes we cannot have good laboratory data of the liquid, and not always the analysis of this liquid is positive. So moreover, the surgeons will need at least a confirmation, tisular confirmation of the IPMN to be sent to surgery, this patient to be treated by surgery. So we will perform first today confocal laser microscopy that probably will give us a little bit more of data regarding this particular lesion in the head of the pancreas, in the for us from the pancreatic duct, and then we will try to perform a fine needle biopsy, but not with but by using the new biopsy forceps through the needle that is called the Murray biopsy forceps. Okay, so we will start with our fine needle punction. Me presta la aguja. So it is, le pusieron antibiótico, sí. We will use expect needle, but the flexible one, because we are in the head of the pancreas, and it's a little bit easier to perform a flexure of the needle to go inside the duct or the cyst. Sí, hay que cargarlo. So we need to preload or confocal probe. ¿Le pusieron antibiótico? This is very important because sometimes it's very difficult to pass the confocal if there is not preloaded. By using the Murray biopsy forceps, it's a little bit easier to pass because it's more rigid. So we are preloading the. Okay. So it's very important that this probe to be just few millimeters inside from the tip of the needle. Sácalo un poquito. No, retira un poquito. Retira. Retira. Okay. Guarda. So now we just preload or confocal probe inside or fine needle or US needle, and we will perform a punction of this lesion. We will use a little bit of Doppler to see if there is any vessel. So we see a important vessel here, and I cannot see my okay now. So we see the plastic part, and I will try to go inside. Okay, we are inside of this lesion, and we will push or probe. Le pasaron el sí, pancreatic cyst. So we start to see the image here. So we start to see the branch here. You see here? This is an IPMN. It's very characteristic. Just here, in the center of the confocal image, you see like the grapes of shape. I can now show you. Necesito la imagen del confocal. Okay. So you can see here the characteristic of the grape shapes that we can see here, and this is tisular lesion. This is very characteristic from IPMN. Okay. So we are 100% sure of that this lesion is an IPMN, and we are confirming that this is a lesion from the main pancreatic duct. This is how we can see the IPMN. You can see the papilla inside. So if this is the atlas that is inside from the machine, so you can compare with your image. As we can see here, we can see the papilla, but there is a little bit of more hyperchromatic areas that probably is dysplasia areas in this lesion. Here you can see there is tisular lesion. There is This is very characteristic of an IPMN. I will try to see a little bit better. This is some areas of dysplasia because there is not more shape. I will try to see here again. Very good image. So we can confirm that this is an IPMN. But there is not just an IPMN. I think there is areas of dysplasia also inside. Here there is hyperchromatic areas, cells inside. There is a loss of the shape of this lesion of the normal characteristic. We saw the so now I will try to pass my I will try to pass my Murray biopsy forces to have some tisular areas for the surgical team, and then we will finish to evaluate this case. Okay. Dame. Dame la pinza Murray, por favor. Momento, yo jalo. Vamos a retirar mejor la aguja. Retira. Así retira. Toma. Retira. Precarguemos la aguja, la pinza Murray, por favor. Hay que precargar la pinza Murray. No sé si podemos. Aquí se ven las papilas, ¿eh? Aquí. Ahí. Aquí. Ok, abre. Mira, ve. Aparte se ve. Hace, empuja, 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 empuja. Ok, retira. Empuja, abre la aguja. Retira. Retira. Retira más. Retira más. Más. Poquito más. Poquito más. Ok. Poquito más. Ahí, guarda. So, we retire of our needle from inside the lesion because the risk of damage of the probe, confocal probe. So we preload again. Now we are with the with the Murray biopsy forceps. So there is not consensus regarding how should be the approach of this kind of lesion. In my practice, I use both because first, if my biopsy comes negative, I have my optical biopsy. Then I can have better result for my histopathology team and for my surgical team. Abre. So we have now the Murray biopsy forces inside, as you can see here. This forceps passed. I will show you here. So this forceps is inside the needle. So through the needle we have here the opening of the forceps, and now I will take a biopsy from the wall of this area of the main pancreatic duct. Cierra. So you can see the close very well, and you can see how it can have a very good tisular biopsy to have a good analysis. We don't have the results of the evaluation of this, but to my opinion, we have at least more than 98% combining these two techniques. So probably in the future should be the approach combining these techniques to have a good results, to avoid unnecessary surgeries in some kind of cystic lesions. This case, for the US characteristic, due to the patient clinical characteristic and the confocal analysis, I am so sure that this patient have an IPMN with some degrees of dysplasia. Abre. So now we are inside again. Just you can see here, the opening of the Murray biopsy forces. This is a very good biopsy forceps. Cierra. Cierra. Now we have, you see here, the wall. So now we are very sure with this that we are taking a good tisular analysis, or at least we will have. So you need to remember that this biopsy forces is 0.8 millimeters that could pass inside a 19 gauge needle, and also we recommend to have at least, if you can arrive to have at least 4 biopsies. ¿Cuántas tenemos? 2, ¿no? Okay. We'll take a little bit more of tissue. Abre. So now we are opening here. We will try to take from another part. Cierra. Momento. Sometimes it's difficult. Okay. Hello. This is a good tissue. ¿Sí? A ver. Sí. I will take one more. Okay, abre. So now we are inside here. I am trying to have from another part here. You see here, we are in another position here. I changed the position of my scope here, and now I will take from this kind of tisular mass inside. Okay, so this could be very good for the pathology analysis. Sierra, you see here. So we are taking just in the tisular area that this is very suspected for malignancy in these kind of cases. Okay, toma. I will perform an aspiration. Dame para aspirar, niña. Dame la jeringuilla. Ok, gracias. I saw the liquid, and it's very. It's not liquid. Very liquid. This is characteristic for the mucinous tisular lesions. You see, there is nothing coming, nothing, because the characteristic of this liquid is different. Is very difficult. You see, nothing is coming, so it's more. There's another data that give us the diagnosis of an IPMN of the main pancreatic duct. There is nothing coming. Yeah, I will try to perform an aspiration, but with my suction to give more power. You can use that also to try to have more liquid inside the needle. That could help you also to send to an analysis. There's nothing coming. Okay. I will finish here. I will retire my needle and I will finish the transmission. Terminamos la transmisión en Bolaños.